We're moving on to pulmonary ventilation. Our learning outcomes here is to be able to identify the muscles of respiration and their roles, develop the nervous system involvement, the brainstem centers that help with the breathing pattern, explain how pressure gradients help air flow and gases flow throughout the respiratory system, identify resistance, understand how they affect breathing and respiration, identify anatomical dead space to alveolar ventilation, define pulmonary volumes and capacities, and define terms and uh, definitions for a normal pattern of breathing. So, very interesting next segment. Breathing, pulmonary ventilation, is a repetitive cycle of inspiration and expiration. Huh? Inspiration and expiration. But in inspiration and expiration, there's also normal or quiet, and there's also forced, which is deep, rapid breathing in emotional situations and also in exercise. Flow of air in the lung depends on pressure differences, and we'll have an idea how that makes the breathing pattern happen. There will also be muscles that will be responsible for this. Let's start with the primary muscle of respiration, the diaphragm. We also call it the prime mover. The diaphragm contracts, and when it contracts, it actually caves downwards, right? Imagine the diaphragm as it is, and then it contracts, it actually gets lower. The level where it is actually gets lower. It contracts by itself. So therefore, it brings it with it the contraction, and it becomes a lower level, gets to a lower level. As it does this, because there's a negative environment or negative pressure inside the thoracic cavity, so when the diaphragm goes down, it pulls with it the base of the lungs, right? It pulls with it the base of the lungs. So when it does that, it makes the lung take in air. It helps to expand the lungs. The diaphragm pulls the base of the lung downwards, so it helps to expand the lungs downwards. Now, meanwhile, the ribs will also lift up, like you're lifting up the handles of a bucket. Okay, remember how you can lift up the handles of a bucket. When they go forward and upward, it helps to, and remember, when they go forward and upwards, they bring with them the thoracic cage. So the lung, which is opposed completely on the thoracic uh, cage itself, when it moves forward and a little bit upward, the lung has no choice but to go with it. And so it expands on its diameter, it goes wide. So, together with this, uh, the external intercostal muscle. There are muscles between the ribs, intercostal between the ribs. The external helps to pull these ribs up. So when the external intercostal lifts the ribs up and the diaphragm contracts to go lower, you actually see the lung get bigger, right? It expands. As it expands, it creates a negative environment lower than the pressure on the outside because it's a space being created. So the higher pressure outside will tend to go in the lungs. So in a way, you're suctioning air as you expand the lungs, and so air will come in, rushing into the lungs, filling the lungs. That's what we want. That's excellent. To what point the Herring-Brewer reflex will be triggered when you have reached that maximum point of expansion, and therefore it will stop there. right? We don't want to damage the lungs by overinflation. So at that point, you now have full inspiration. This is still normal inspiration, huh? And you know what happens after that, right? Oxygen high in the alveolus will diffuse into the capillary vessels to go into the red blood cells. So 100 on the alveolar side, estimate 60 millimeter mercury on the vascular side. It will now go into through the walls of the alveolus, through the walls of the capillary into the blood vessel. Right, so you have inhaled. Your oxygen now is in the circulatory system through in the red blood cells. That's amazing. Now, what happens next is expiration, normal expiration. And what happens with that is the muscles, all they have to do, the external intercostal, is to relax. When the external intercostals relax, the ribs will go down and therefore decreasing the size again. The diaphragm, who is at the bottom, will relax and will tend to go up. So as this goes up, the ribs go down, you actually flatten or squeeze out the lungs, right? And by doing this, you actually squeeze out carbon dioxide. Is that amazing? You actually squeeze out carbon dioxide. And carbon dioxide will favor to go out because the pressure difference will favor carbon dioxide to go through the alveolus into the conducting division into the atmosphere. Okay? And remember, we did not use any muscles to expire in the normal process. All we did was to relax the muscles. That's very important to understand, huh? So, in this situation, the nervous system, which we will tag the next few slides, will trigger another circuit. It's actually using a reverberating circuit, where after the first process, a signal comes around and stimulates the diaphragm again using the phrenic nerve. Phrenic nerve. The diaphragm goes down again. The intercostal muscle external goes up again, and you now have your next inhalation or your next breath of air. Okay, so this goes on, right? In a rate about 12 to 20, sometimes 12 to 18. So when you do vital signs, you should know the normals, right? The regular blood pressure, the regular respiratory rate, 12 to 20, right? You should know the angles of the limbs. That's all part of the physical exam. But for the vital signs, know your blood pressure, pulse rate, and also know your respiratory rate. Okay. Now, having said that, the next item is to be able to address it when we actually need to breathe with force. Okay. Let's start with forced inspiration. In forced inspiration, you may need to call in additional muscles. And to better visualize it, in order for you to breathe completely and fast, maybe faster than normal breathing. For example, you're exercising, you need to load up quickly. The best way to fully inspire air is when you are in an erect position, right? When you want to breathe in air, what you do, sometimes you put your hands on your waist and you take a deep breath of air. What did you just do? You just straighten up your torso, right? Your thoracic cage. And in fact, you try to also straighten up your larynx so you can completely let air in. Okay. The muscles that you use to attain this position are the accessory muscles of inspiration. And if you think about it, the back muscles trying to put your posture in that pattern. The muscles of your the trapezius pulling back so you can have a better chest expansion. Your pectoral major, your sternocleidomastoid, right? All these are trying to pull up your ribs in a good position so you can breathe in, right? So I need you to remember in forced inspiration, all these accessory muscles that we mentioned help to attain a comfortable position so you can force air in. You're trying to inhale air in. Of course, the diaphragm and the external intercostal are still working while these other muscles are trying to help in. So you get your full inspiration faster, probably more. You get more air by doing this, not just the normal volume that you usually use or the tidal volume that you usually use. And again, at the peak of this inspiration, we then go with expiration. After inspiration follows expiration. If it was forced inspiration, okay, if it's going to be continuous, you'll end up having using forced expiration as well. Okay, so in forced expiration, and sometimes you just take a deep breath, that's done. But in forced expiration, you have to force the air out. When I say air, I mean the gas out, carbon dioxide. So imagine yourself pushing air out. Would you not bend your torso? Would you not bend your chest downwards or pull your chest downwards? You will use your abdominal muscles to do this. You will use your set of abdominal muscles in order to bend, curve, and using really your abdominal cavity against your respiratory cavity, thoracic cavity, in order to sort of help squeeze the lung to get the gas out, which is, and I mean the carbon dioxide, okay? To get the carbon dioxide out in a forced expiration, right? So now you're using accessory muscles of forced expiration, specifically your abdominal muscles. Okay, so that's how all these muscles get into play. Huh? And this will continue until your body needs to do so. Either you're still engaged in the event or you just want to keep on doing this. But keep in mind, as you blow in and out the gases, you may attain some levels of low air or high air, depending. So that will again affect the physiological status of the body. All right, good. Valsalva maneuver, while we can use it to push out air, we can also use it by loading us up with air in our thoracic and using it against the abdomen and the pelvic area. Therefore, it can be used for childbirth, urination, defecation, and also vomiting. Here in this diagram shows you muscles in blue, right, which is used for inspiration, and you'll have muscles in green, which is used for forced expiration. Okay, gives you that good idea. Now let's go to the nervous system role. We call it the neural control of breathing. There has to be, and there is, a pattern of breathing that takes care of our ventilation. Now, it will then depend on the skeletal muscles that help to expand or initiate breathing. There is no autorhythmic pacemaker in breathing, just like the heart is. It's all about repeating itself. Instead of a pacemaker, it has a circuit in the brain. We call it a reverberating circuit that comes around to start a new respiration. Okay, let's go there right now. In the brainstem, there will be three. First is the ventral respiratory group, we call VRG. This is the primary generator of the respiratory cycle or rhythm. This is the default, which takes care also of your quiet breathing. We call it eupnea. And then it also has expiratory neurons that help the muscles relax. And then at the same time, it will have an inspiratory neuron that triggers breathing again. So you'll end up at least 12 breaths per minute, and we usually say to 18. Same time, you will have, if that's a VRG, you will have another one called DRG, dorsal respiratory group. DRG would depend on the influence from other sources outside of the body. The rate and depth of breathing in DRG is also changed. Huh? For example, you have a situation where there's too much acid in the blood, you might end up increasing respiration. So the DRG works by picking up information about how the blood is, the acid base level of the blood. It will also have receptors feeding it on how the pressure is in the circulatory system, which also affects breathing. All other parameters go to the DRG, and the DRG may increase or decrease the respiratory rate to compensate for all these situation or changes. When this is done and we have compensated, it will switch back to VRG as our default pattern of breathing. Now, when the individual is engaged in other conditions like emotional, laughter, crying, okay, singing, maybe something that is done on purpose or is a consequence of our emotional situation, then breathing also changes. Huh? We end up breathing more heavily, sometimes fast, right? Sometimes a little bit slow, depending, but it changes the pattern of breathing. At this point, the Pontine respiratory group, huh? The Pontine respiratory group is the one that takes over. It will modify the rhythm of the VRG and also the DRG. Okay? It will adapt to cases like sleep, exercise, vocalization, emotional response. It will adapt to that. So the pons will be the one responsible for that. Visually, here's the brainstem, and I got the midbrain, the pons, and the medulla oblongata. In the medulla oblongata, there's a ventral and dorsal respiratory group, and that's where we got this terminology, huh? This is the ventral. There's a ventral and respiratory group for this. The pons has the third one, which is PRG, Pontine. Uh, the PRG actually helps to create the emotional situation. And this is the Pontine respiratory group. All right, good, huh? And this is basically what we describe for the DRG. Inputs from that. DRG also is affected by the pressure all around the blood vessels, okay? The prime blood vessels, like your aorta, like your carotid artery. You can also voluntarily push air, as for example, in a wind instrument, and you take it away from VRG momentarily. Okay. There are also some methods that apply. For example, the flow of a fluid is directly proportional to the pressure difference between the 2 points, or the flow of a fluid is inversely proportional to the resistance. So there's in respiration, there is also a resistance known. The atmospheric pressure drives respiration. 760 millimeter mercury will always try to be the same in other parts of the system, and so it tries to drive that to that level. In Boyd's law, at a constant temperature, the pressure of a gas is inversely proportional to the volume, because at constant pressure, if a certain box has dimensions, if I push the top, right, if I have to push the top and put pressure on it, it will go down, but the volume will decrease because the box level at the top has already gone down. So there's a good example of Boyle's law, huh? Unit for pressure in respiration is centimeters water, huh? Unit of pressure for blood is millimeter mercury. Intrapleural pressure is slightly negative, well, actually negative, between the pleural layers. So it will end up keeping the lung opposed to the wall at regular times. Right, then what happens, like this just describes what we already mentioned, which shows that the outside alveolar forces will affect the inside, right? And therefore equalize itself. The visceral pleura, clinging to the cohesion of the water, follows the parietal pleura, and there should not be a space between them. Huh? Another law is that of Charles, where the volume of gas is directly proportional to its absolute temperature, meaning the temperature can affect the volume in a specific area. It can expand, it can constrict the volume. Huh? In quiet breathing, a dimension of the thoracic cage increases only a few millimeters, huh? But that increase is overall on the side, so it actually is a good amount of volume. Here's to further illustrate the rib cage as it goes up and how the external intercostal lifts it in normal inspiration. By the way, the external intercostal helps with normal inspiration as it lifts the ribs. You may wonder what the internal intercostal's role is. The internal intercostal will work when you are doing forced expiration, huh? Forced expiration. These terms will be a good candidate for our bag of odds because if you're inspiring, you're actually going to use your external intercostal, and when you are forcefully expiring, that's when we need your internal intercostal. Okay. Oops. Let's see this. Pneumothorax is the presence of air in the pleural cavity. Either it was traumatized and air got in. At this point, the air will occupy space, and then the occupied space will be lesser volume for the lungs. Huh? At the same time, you let the negative pressure leak out, and therefore the lung may recoil, get smaller, and not be able to expand that much. That's really a dangerous situation there. If it finally collapses, then you have the condition called atelectasis, and maybe needing some special skill in order to pump air and hopefully bring it back to normal expansion. Resistance also decreases in the airflow. Factors that affect that are obviously the diameter and the compliance of the lung itself. If you have a condition where it ended up bronchodilating, then you can have more passage of gases. Fight or flight situations release epinephrine, and therefore epinephrine actually makes you bronchodilate. Huh? Epinephrine. Bronchoconstriction happens in cases of allergy or asthmatic situations. Histamine, parasympathetic nerve, cold air, chemical stimulate or favor bronchoconstriction. The air is less, and you'll end up with suffocation if it's extreme constriction. Anaphylaxis and asthma are also common entities that affect this. Factors that influence airway resistance also is compliance. Huh? The lungs should expand when needed in order to get air, but sometimes it will have a hard time expanding, as in the case of lung diseases. Also, the surfactant should be available and a good in amount in order to help the lung expand also. Without it will also be a problem. Now, there are spaces in the respiratory system that are useful spaces, and there's also anatomical spaces or conducting zone of air. Huh? In pulmonary diseases, some alveoli may be unable to exchange gas because of the block in the process. Oops, wait a minute. Okay, uh, as far as that is concerned, let's go to this anatomic dead space. Huh? There's a graph here. We will use, if it was an experiment, we'll be using a spirometer. It's a device that measures air being pushed out. It will be able to define the volumes inside the lung itself. Residual volume is a volume that's hard to measure. That's almost like part of the dead space. It usually is gone when a person is deceased. Huh? Tidal volume is the volume that we normally inhale and exhale. That normal uh, volume is what we use for when we're sitting down, where we're not doing anything active. But you will also have inspiratory reserve volume and expiratory reserve volume, and you can see them. Here's a patient using an inspiratory uh, spirometer, right, measuring the air that he can push out. Take a check on this graph here. This graph will show the one in yellow. If you follow the area in yellow, that's your tidal volume. The volume that you use on a regular basis, relaxed, relaxed. Like now, you're listening to the lecture. That's like a relaxed state. You are in your tidal volume. Okay. If you inhale, so if you're inhaling normally and exhaling, that's your tidal volume. But when you inhale an extra amount, that's your inspiratory reserve volume. When you exhale, right, normally, and then after the exhale, you exhale some more, that volume is your expiratory reserve volume. Okay, we mentioned reserve because when you start walking faster, moving faster, you may need to pump more air. And so those vital volumes are available for that expansion. Now, if you add the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume, you have what you call your vital capacity. It says there, vital capacity. If you add the residual volume, then you will have the complete lung capacity, The complete lung capacity. Okay? So remember these volumes, and you can experiment on yourself, Normal breathing up and down, normal breathing. And then at the end of inspiration, expire. At the end of inspiration, normal inspiration, you try to breathe in as much air as you can. And when you peak that, that's your um, total lung capacity at that point, and your top of your inspiratory reserve volume. And then you exhale that and go back to tidal volume. Inhale, exhale, inhale, exhale, then inhale, then exhale, and then, right, completely push all the air out. Right. At the end, you're ready to breathe again. That's fine. But the amount that you pushed out when you came all the way from the peak is actually your vital capacity. Okay? All right. These are the results of spirometry testing. Now, out of this, the mathematical picture is really your total lung capacity is equal to the volumes that I mentioned plus the uh, capacities like vital capacity. So this really gives a picture of the experiment on spirometry. There are diseases in the lung that might restrict your expansion, huh? And these are diseases like black lung disease, tuberculosis that are actually in the tissue of the lung. It will define across your restrictive disorders. There's also disorders that are obstructive, and some examples are asthma, chronic bronchitis, allergic reaction can also be obstructive, creating the vessels to become smaller. Emphysema combines element of restrictive and obstructive disorder as well, but it's also a condition of the lung. Right? Let's go to some terminologies. Normal breathing, always remember EU means normal, huh? Eupnea, eupnea, where PNEA is Latin for breathing. So relaxed breathing is eupnea or eupnea. Uh, Cessation temporarily of breathing is apnea, and difficulty of breathing is dyspnea. Increased breathing is hyperpnea and hyperventilation, especially in cases of pulmonary ventilation, hyperventilation. Remember that EU is normal. You could also use it in phoria or physical condition. So it will be euphoria, which is a happy, more relaxed um, condition. Hypoventilation is reduced pulmonary ventilation. When a diabetic is having an attack and is breathing deeply, like you call that Kussmaul breathing, and that's the brain driving the body to get rid of carbon dioxide as soon as he can. It could also be a position where a patient can sleep or breathe well in a flat bed and needs some elevation at the back. We call it orthopnea. Breathing where you pay respect to the position. Respiratory arrest is permanent cessation of breathing. Again, non-permanent would be if permanent cessation is arrest, apnea is your temporary cessation of breathing. Tachypnea is accelerated respiration as well. Huh? All right, let's go to this next topic, gas exchange and transport. Huh? Air is 78% nitrogen, 20% oxygen, a mix of many gases. So every part of this is a complete set. So the parts we call PO2, the pressure of O2, P, carbon dioxide, and so on and so forth. These are all a mixture of gases with some dominance. Dalton's law said that total atmospheric pressure is the sum of the contribution of the individual gases. So if all of them affords a certain gas, it will have a certain pressure. So when combined, that will be your atmospheric pressure. Okay. Now oxygen gets diluted and enriched when air is combined. We can diffuse air from 100 to 60, moving towards the direction of lesser osmotic concentration. But depends on the gas as well. Huh? In the carbon dioxide, it went from 60 to 40 outside the alveolus. But if you look at it, you only got 20 units. Huh? And therefore, it shows that some gases are more easily diffused. They don't have too much pressure needed, and they will diffuse easy. It just depends on the gas. Huh? There's a alveolar gas exchange where you have oxygen and carbon dioxide switching, like we paid attention to some slides back, right? Water will oxygen will dissolve in water, pass through the respiratory membrane, and then carbon dioxide uh, leave the blood as it may pass another way, where it can easily diffuse into the compartment. Gases diffuse from the gradient from higher to lower, huh? Also remember that. Temperature affects the air-water surface as well. That's your Henry's law. Amount of gas that dissolves in the water is determined by its solubility in water and partial pressure in air. So that's your Henry's law. Other various factors can affect the physical stature, especially the alveolus. Huh? It's also important that each gas is controlled and maintained. When another gas is higher than the others, it may also create some conditions as an effect of that. Okay. Let's go to pressure gradient of gases. P, the normal gases usually go in and out through from high to low, huh? It's a matter of diffusion. At high altitudes, the partial pressure of gases are lower, and therefore you tend to. What happens when you have end up with low oxygen in the blood is it will trigger your kidneys to produce renin, especially the volume of blood. When renin is produced, you activate the renin angiotensin aldosterone mechanism, which leads to increasing volume and pressure in the system. And that's a topic in urinary system discussions. We'll get to that also, huh? But the fact is that you are in hypoxemia to begin with, or hypoxia, low oxygen in the blood. We also mentioned that sometimes there is a lot of pressure and oxygen pressure increases. Huh? Then that's in your hyperbaric oxygen therapy. If you think about this pattern, it coincides with the flow of blood. What it means is, for example, oxygen, which is, let's say, 90 or 100 from the alveolus, while there's only 60 in the bloodstream, it will tend to go into the blood. As it goes in the blood, some of the units may be, scrubbed off because of the passages through the vessel, but it may reach an organ, like for example the heart. Actually, from the lungs, blood is passed to the heart, and the heart passes it to other organs. And this is an example of a new organ here. So you have blood that is oxygenated, and it's actually around 90, right? Huh? Or a higher number, but the organ itself will have a lower level of oxygen because it just used it. So it will diffuse into the organ, and the organ will be filled up and content. Now, as the blood passes to the capillary level and has diffused the oxygen into the organ, remember that it is also low in carbon dioxide, having come from the lungs. So your carbon dioxide will be lower, and the oxygen in carbon dioxide in the organ is higher, so it will enhance pushing out carbon dioxide to the blood vessel. Now, when the blood vessel picks it up, it will now travel back into the right atrium, back to the lungs, and the pressure will be carried in there. You now have 60 millimeter mercury and in deoxygenated blood. When it gets to the alveolus, like we said, the alveolus has only 20 to 40 millimeter mercury. It favors moving carbon dioxide from the blood to the alveolus. Any change in this situation will end up in a disease. Oxygen loading is also important. Um, Air in the hyperbaric chamber will load up faster, and once it is loaded up, it will combine with available oxygen carrying red blood cells and be able to equally subdue itself, meaning complete its infiltration. This is pressure gradient of oxygen, and this other part is your ambient uh, pressure. You can see a downward trend in the gradient in oxygen diffusion and a downward reduced gradient as the oxygen slowly diffuses. Here's a picture of the alveolus in its normal condition, thin and healthy looking alveolus walls. And here's a picture of a person who developed pneumonia. See how the vessels are more thicker, inflamed, huh? Right? And here's another picture of when the blood vessels collect, break down, and join to make a bigger blood vessel, or instead of blood vessel, a bigger alveolus. See here, the alveolar wall are intact, but when they break, they create a bigger alveolus, which looks like it's a lot more efficient, but it actually is less in pressure. Look at this alveolus that broke into almost like four big ones. So the pressure to compensate for that is bigger, and your thoracic cage will have to adapt to it. Huh? Eventually, this person ends up having a barrel chest. He is suffering from emphysema. Okay, barrel chest symptom and sign. The membrane thickness should not be uh, too thick because it will have a harder time to pass through. But sometimes it gets thick because of a condition. In another case, uh, pneumonia will make it thicker. So exchange of gases is harder. You can also have some membranes that may help to decrease the pain or increase the pain. Okay? Right. This mentions that for every breath every breath that we take, when we fill our lungs, the lungs expand. But they expand depending on the volume that's given to them. Huh? There's a good ventilation perfusion. You give me the same amount of volume, it not only makes you healthy, but it recirculates the air again. Huh? So it usually matches how much pressure you put in. Right? Huh? And do not forget your note taking that the patient is ventilating well. Patient has this oxygen levels. You do that uh, clinical technique, and no sign, and there's urine output if the patient is in catheter. All right, gases go in and out of the lung or pulmonary circulation, bound to the hemoglobin, and carbon dioxide is at first disengaged from the actual cell and stays alongside it, and when they get to the lungs, they combine again. Huh? Atrial arterial blood carries about 20 ml of oxygen. Hemoglobin tries to cope up and be able to carry that oxygen. You need four protein globin portions for maximum uh, inspiration, right? And there's good enough oxygen there. This curve shows you that at the beginning, the first red blood cell gets the oxygen. It will be slow as it goes. It's more shallow here before it bends upwards. This is the picture of how it is in the beginning. But as more red blood cells load up and oxygen are being filled up with are filling up the red blood cells, there will be a point in time that no matter how much oxygen you put in, the red blood cells have already been saturated, and thus giving you the leveling part at the end of this curve. Carbon dioxide is transported in three forms as carbonic acid, carbamino compound, and dissolved in the plasma. This is your equation for that picture where you have carbon dioxide plus water coming into bicarbonate and coming into your HCO3 plus H ion. HCO3 is a bicarb, huh? All right. It says that it's 5% for the amino acid to form into carbamino compounds, which will be used later on, huh? You can also have 5% of its blood in dissolved gases, huh? It's always a mix of gases. That's why we call them partial. When you say T, meaning it's partial pressure of this, partial pressures of this, partial pressure of another item, huh? Carbon monoxide, which is another chemical, not carbon dioxide, competes for the binding sites of the hemoglobin. Therefore, if it occupies it, then oxygen don't have time to or a place to connect with it, and therefore end up in hypoxia. Okay. Other gases are not right away identified. They're colorless, but they show their signs and symptoms in a patient as far as application of that is concerned or as far as the level of gases are concerned. Carboxyhemoglobin is the carbon, the CO, carbon monoxide that binds to iron. Smoking and, in many cases, a room where there's a lot of carbon monoxide can result in that in poisoning. This shows the carbonic anhydrase and ALBC catalysis or catalase. Huh? Systemic gas exchange is when you unload oxygen and load carbon dioxide so you can get rid of that in normal inspiration and expiration. This is the same as the curve that we just described. So here's your red blood cell, right? And here's your respiratory tissue. Okay, so what happens is that you will have a high level of carbon dioxide going into the red blood cell. This is the tissue of the organ. So they're high in carbon dioxide. They will unload towards the red blood cell, while the red blood cell takes this opportunity to unload good gas there, good blood, the oxygen, actually oxygenated blood. This is from organ to the blood vessels. And when you get to the blood vessels, it will bring the blood all the way to the lungs. And in this wall here, it's going to pass it to the alveolar cells, where the alveolar cells also get oxygen back to the muscular system. So it's a good exchange, huh? What you got in one place and then how you deliver it to the next place. Okay, that ends this part, and let's take a break, and then we'll continue with possibly items here. Let's see if we still have some slides. Okay, we'll take a break and then come back to discuss this. I'll see if I could fix this. Okay.